Good morning, everyone. Welcome to today's lecture. Franz von Stauffenberg is a third-year resident, and he will talk about pancreas transplantation. So please enjoy.
Thank you for introducing me, dear colleagues. The purpose of this presentation is to give you an insight about pancreas transplantation and to evaluate the need of pancreas transplantation in 2021, where we have evolving conservative therapy options for the underlying disease. I will begin with a short recap about the history of pancreas transplantation, tell you why, who, and when to transplant, talk about the paradox because nowadays we have a better outcome but decreasing numbers, and talk about the surgical techniques and the postoperative complications, as well as how we should measure the outcome and the success of the transplantation. The first pancreas transplantation was performed in 1966 by Dr. Kelly and Dr. Lillehei in Minnesota. It was a simultaneous kidney and pancreas transplantation for a patient with type 1 diabetes and end-stage renal disease, and he was insulin-free for 6 days, and the graft survival was 2 months. In the upcoming 4 years, there were 25 pancreas transplants performed, and only 1 case functioned for 1 year. In the next 10 years, there was a total of 105 cases performed. As you can see, there were mainly segmental grafts used, and there were different techniques for dealing with the exocrine function of the pancreas, for example, injection of the polymer into a pancreatic duct or performing a duodenostoma. Until 2017, there were more than 50,000 transplantations performed in more than 200 centers worldwide. But why do we even perform pancreas transplantation? As you can see in this graph, for patients with type 1 diabetes and renal disease, performing simultaneous pancreas and kidney transplantation has the best outcome compared to a live donor kidney, which becomes evident 4 years after the transplantation. And it's also superior to the deceased donor kidney, and all 3 transplantations are superior to dialysis, as you can see on the right. But SPKs, like the simultaneous pancreas and kidney transplantation, is not only improving patients' lifetime, but also their kidney function, which also becomes evident 4 years after the transplantation, which is due to the good glycemic control we reach by the pancreas transplant. And the procedure is not only life extending, but also life enhancing. We reach insulin independence for the patients, which is improving their quality of life. And by that, we can reduce diabetic complications. Can one of the residents tell me what the major diabetic complications are?
So there's, for example, diabetic nephropathy, polyneuropathy, vascular diseases, and fatty liver disease.
Thanks. And do you also know about the acute and life-threatening complications?
Could be hypoglycemia, hyperglycemia, to name a few.
That's right, thank you. So we don't only reduce the complications of the chronic complications of diabetes, as you can see here, but we also reduce the life-threatening complications like hyperglycemia or ketoacidosis. We improve the long-term outcome for patients, and we significantly improve the kidney function by performing simultaneous pancreas and kidney transplantation. When talking about indication and therapy options, we have to understand the pathophysiology a bit. We have a genetic susceptibility leading to a destruction of the beta cells, which are located in the Langerhans islands in the pancreas, and they produce insulin. When they are destructed, we have a lack of insulin, which leads to type 1 diabetes, leading to hyperglycemia, which leads to diabetic nephropathy and end-stage renal disease. So we can address the destruction of the beta cells in the end-stage renal disease. The options for only destruction of beta cells are insulin therapy, islet transplantation, or pancreas transplantation alone. For the renal disease, we can perform kidney transplantation alone, or we have the conservative therapy option of dialysis. But if we have both diseases present, then we can either combine the conservative therapies. We could also perform islet transplantation with or after kidney transplantation, or we could do combined transplantations like the simultaneous pancreas and kidney transplantation or the pancreas after kidney transplantation. In this lecture, I will focus on the solid organ transplants. As we now know about the different therapy options, we should evaluate which patient qualifies for what kind of transplantation. So if we have a type 1 diabetes patient with a GFR over 30, but he has the so-called brittle diabetes, which is especially hard to control, and there's many episodes of severe ketoacidosis or severe hypoglycemia, or we have patients with hypoglycemia unawareness who don't feel that they are hypoglycemic, then we can perform pancreas transplantation alone. If the kidney function is already impaired or the patient's already on dialysis, we should perform SPK or pancreas after kidney transplantation. But we mostly perform SPK nowadays. So now we know about the indications, therapy options, but it's also very important to choose the right timing for the transplantation. As you can see on this graph, patients with SPK in green compared to patients on the wait list, there's a way better survival in the SPK. After 4 years, they have a survival of 91% after receiving SPK, and on the wait list after 4 years, survival is only 46%. The same goes for the duration of dialysis before the transplantation. If we perform preemptive SPK, we have the best outcome for the patient, and the longer they are in dialysis, the worse gets the outcome. This also goes for the kidney graft function and the pancreas graft function. So we should perform the transplantation as soon as possible, and the best is to perform it before patients are on dialysis. As you can see here, the later a pancreas transplantation was performed, the better the outcome gets. So we can say it's a story of success, as we also have a longer graft survival, longer patient survival, longer insulin independence, and less surgical complications. We also have a rising incidence of type 1 diabetes worldwide, so we could presume that the numbers of pancreas transplantations would also increase. But since 2003, we have a steep decline in pancreas transplantations. This decline can also be seen here. Here you see that we mainly perform SPK, which you see on the triangles, and there was a decline from 2003 on. And in the US, there was even a decline of 30% in 1 decade. The decline in pancreas transplantation, of course, had an impact on the individual centers. As you can see here, the median center volume decreased from 9 to 5 transplants per year, and the lower and upper quartile values are 3 to 10 pancreas transplants per year. Anyway, there's only a low number of pancreas transplantations compared to other solid organ transplants. Here you see the transplantations performed in 2019 by Eurotransplant in blue and Swiss Transplant in green. And you can see that pancreas transplant is only a small fraction of the solid organ transplants. That it's a low number can also be seen in the center size. A pancreas center is defined as a small center, a low-sized center if it performs less than 5 transplantations per year. It's middle-sized if it performs 5 to 10, and a large center if it performs over 10, which is a small number for a large transplantation center. For example, liver transplantations are defined as a large center if you perform more than 88 in a year. So by that, we have less transplantations, which leads to less centers and less trained surgeons, which could already be an explanation for the decreasing numbers. The paradox becomes even more paradoxically if we watch at the patient survival and graft function. And you can see that we have a significant increase in survival and function over the years. We also have less technical graft loss, especially in the 1990s. There was a steep decline in technical graft loss. And for example, if we compare graft thrombosis, in 1998, we had 27% of graft thrombosis, while in 2012, only 5.1% of graft thrombosis. We also have less immunological graft loss. Nowadays, it's typical to be under 5%, and it's especially low in SPK. But finding an obvious reason for the decline in performed transplantation is not easy, as it is a multifactorial problem. One cause could be the decline in overall donor quality, as we have an increase of donor age and BMI, leading to more high-risk donors. And we also have more DCD donors nowadays compared to before. And also, pancreas procurement is quite difficult, and there's organ damage in up to 50%, which leads to not accepting the pancreas. And we have more injuries in procurement teams from centers without pancreas transplantation programs. Another reason could be the lack of referral source, as centers without pancreas transplantation programs retain patients for kidney transplantation only. And we have a diversion of interest, as we have improvements in diabetes management, education, and awareness, and we have way better glucose monitoring and insulin application with pumps. By that, we have a delay of diabetic complications, which leads to a later referral for the transplant, and then the patients are older, might have other comorbidities, and have a higher risk, so we are less likely to perform the transplantation. But as we still perform it, and we will keep performing it, I want to tell you something about the technical aspects about it. So as you can see, we take out the donor's pancreas with a part of the duodenum, because through the duodenum we can guarantee an exocrine drainage for the pancreatic enzymes. We then take a Y graft from the patient's iliac artery and connect it to the SMA and the splenic artery at the pancreas. And then we use the portal vein for the endocrine drainage for the insulin to get in the body. It's quite a long backtable preparation, and we try to keep the cold ischemia time under 12 hours because a longer cold ischemia time is associated with a higher graft loss. Here you can see an operative image where you have the donor's duodenum, the head of the pancreas. Here you have the Y graft connected to the SMA and the splenic artery, and here is the portal vein for the endocrine drainage. After procurement, we have to decide at which site we should perform the anastomosis in the recipient. While the arterial anastomosis always is an end-to site to the common iliac artery, we have two options for the venous drainage. We can either perform portal venous drainage, which goes as an end-to site to the superior mesenteric vein, and as you can see here, then we have a first pass effect of the insulin through the liver. The other option is a systemic venous drainage, where we have an end-to-site anastomosis to the common iliac vein, and there's no first pass effect for the insulin as it's systemically applied. The initial idea about the portal venous drainage was that due to the first pass effect, there would be no hyperinsulinemia, and it was also thought that we would have less rejection because of the hepatic clearance of the antigens shed by the allograft. And also the situation is more physiologic. But we have to watch out because portal vein thrombosis can be a complication of the portal venous drainage. The systemic venous drainage, on the other hand, is technically easier to perform, but it was thought to lead to peripheral hyperinsulinemia, which is linked to an increased risk of atherosclerosis and can also lead to peripheral insulin resistance. So when we compare those two types of drainage, there was a study comparing 25,000 systemic venous drainage with 5,000 portal venous drainage, and they made a Kaplan-Meier estimate, and they saw that the systemic venous drainage is even superior after 10,000 days in patient survival and graft survival. So it seems reasonable that by now, as you can see here, only around 10 to 20% of the pancreas transplantations are performed with a portal vein drainage. Besides the endocrine drainage, we also have to ensure a good drainage of the exocrine pancreatic enzymes. There originally also were two techniques. The one is the bladder drainage, which is a side-to-side duodenocystostomy, or the enteric drainage, which is a side-to-side duodenogenostomy to the proximal lumen. The advantages of the bladder drainage are a reduced infection rate as the recipient's gastrointestinal tract keeps untouched. And we have a cystoscopic access for the biopsy. We can use urinary analysis to monitor the graft function. But we have a wide range of urological problems and many metabolic and volume problems such as metabolic acidosis and dehydration. Those problems lead to enteric conversion in patients with bladder drainage in up to 40%. The enteric drainage, on the other hand, has less urologic and metabolic complications, is more physiologic, and treats exocrine insufficiency if needed. But we have more infection, leakage, and pancreatitis, and we don't have endoscopic access to the allograft, and we can't use urinary tests. But as the disadvantages of bladder drainage outweigh those of enteric drainage, nowadays more than 90% of pancreas transplantations are performed with enteric drainage, and we don't recommend to use bladder drainage anymore. Here you can see an intraoperative picture of the systemic vascular drainage. You have the portal vein anastomosed to the common iliac vein, and you can see the duodenogenostomy for the exocrine drainage. Even if we choose the optimal endocrine exocrine drainage, we still have to deal with a relatively high rate of surgical complications. Around 70% of early graft losses are due to technical problems, and we have relaparotomy rates up to 32%. And of course, we have typical problems like bleeding and infection, but in pancreas transplantation, we have to be particularly careful for graft thrombosis, exocrine leak, and pancreatitis. The most frequent reason for early graft loss is graft thrombosis. It occurs mainly in the first 48 hours, but can show up to 6 weeks after transplantation. It happens in 5 to 10% of pancreas transplantations, so we have to administer an early anticoagulation to prevent it. Venous thrombosis is more typical than arterial thrombosis. And maybe one of the residents could tell me what the symptoms of a graft thrombosis could be.
Spontaneous hyperglycemia and abdominal pain.
Thank you, that's right. We have a rapid increase in glucose leading to hyperglycemia. We can have abdominal pain. We might see elevated amylase, and we could see melena or hematuria depending on where the exocrine drainage was performed. We can perform ultrasonography to see the thrombosis as shown here by the blue arrows, but it is actually advised to perform CT scan because we don't want to lose time. The treatment of choice is immediate surgical revision, but we have almost 100% of graft loss when we have graft thrombosis. Other technical problems are the exocrine leakage. It happens in 4 to 10% of transplant patients with enteric drainage, and the early leaks are usually due to ischemia or related to the anastomotic technique. The risk is higher if the patient had a pancreas after kidney transplant or other reasons for preoperative immunosuppression, and it can be complicated by abscess or fistula formation. In the CT scan, you can see an enteric leak. You have on the white arrow, you have the suture line from the duodenum, and next to it, the fluid collection. Symptoms are peritonitis, fever, and leukocytosis, and the therapy of choice is surgical debridement and repair, but we might have to perform pancreatectomy because of active pancreas enzymes at the anastomosis preventing the healing. It's contributing to 4% of the graft failures. Another problem we have in pancreas transplantation is pancreatitis. Until today, there's no clear definition of post-transplant pancreatitis, but a mild form can be seen due to reperfusion injury in 10 to 20%. And we should see an amylase peak after transplantation within the first 24 to 48 hours after transplantation. A severe pancreatitis can happen in 3% of patients. It's also due to reperfusion injury and can also be associated to narrowing of the pancreatic duct during the surgery. It can be complicated by pancreatic abscesses, necrosis, fistulas, or pseudocysts, and is a risk factor for graft thrombosis and graft loss. But graft thrombosis can lead to pancreatitis as well. The differential diagnosis is acute rejection, and it should be treated as acute rejection until proven otherwise. And here we have a sonography image where we can see an edematous pancreas. Here is the head, the body, and the tail of the pancreas, and the white arrow heads show fluid accumulations. On a CT scan, where the star is located, you can see an enlarged pancreas, and on the arrowheads, you can see pseudocysts. Another problem we have is not a technical problem, but rather a definition problem, because until today, there's still no standardized definition for the graft survival. Different sources in the literature talk about, for example, as a graft survival, no insulin at all, or low-dose insulin, but no acute diabetic complications. Some say even if the pancreas is not removed, the graft is surviving, and some say that the HbA1c control is the most important factor. We think that the best one to choose is the insulin-free survival. The significant difference in choosing absolute insulin independence as definition can be shown by the results from the EXPAND study. They had the EDC group with older patients with a higher BMI and the standard group. When they present their results with the definition of graft survival as the pancreas allograft is producing a detectable C-peptide, but the recipient might require insulin treatment, we can see that 3 months postoperatively, the EDC group had a survival of 100%, a graft survival of 100%, and the standard group of nearly 95%. But if we now compare the same study results with insulin-free graft survival, we can see at 3 months the EDC group only has 83% survival and the standard group only 67% of insulin-free graft survival. And this major gap we can see here is the reason why we choose to use the absolute insulin-free graft survival as survival. I want to finish my presentation by showing some of the data of our own pancreas transplantations from the last 20 years. We performed 139 transplantations and 94% were primary SPK procedures. As you can see here, the HbA1c control was reached after 6 months and was stable at 12 months after the transplantation. Also, kidney function was good. As you can see, the patients were dialysis-free at nearly 98% 5 years post-transplant, and the GFR remained stable above 65, also 5 years post-transplant. We have an overall patient survival of around 90%, up to 10 years after the transplantation. And we have an insulin-free graft survival of around 80%, 10 years after transplantation. So by that, we can say that pancreas transplantation is a story of success. To sum up, the pancreas transplantation, or the simultaneous pancreas and kidney transplantation, is still the gold standard for patients with type 1 diabetes mellitus and end-stage kidney disease. We have improved patient survival and graft function over time. We have lower surgical morbidity over time. It is not only a life-enhancing, but a life-extending procedure. We can reach optimal long-term kidney function, but we still have a lack of consensus regarding the best definition for graft survival. Thank you for your attention.
Thank you, Franz. You gave us a very nice overview on the history and the current state of pancreas transplantation. And you really nicely explained us about the history and the current state and the indications, and you nicely explained why pancreas transplantation is still considered the gold standard for patients with type 1 diabetes and chronic kidney disease. I think the key point or the main message should be from this presentation that there is a paradox, and it's difficult to explain and difficult to overcome. We have better outcome over time, so we were able to lower especially the surgical morbidity over time. However, we have this decline in numbers. And this is, as you said, multifactorial and has a lot to do with the older times where the surgical morbidity was especially high and pancreas transplantation was considered a high-risk surgery. So I think this is the main part to overcome in the future, because we think that there is still a role, and we could show that also with the very good results, especially for long time insulin independence and kidney function. So we are open for your questions.
Maybe I start. Number one, congratulations. I learned a lot, and I think indeed there is a number of questions. I would first to congratulate the group here. The data that you show is just outstanding. The team from Dr. de Rougemont and others here. This is really impressive, and I think that's just confirmed that the results are good. I think, just thinking one of the reasons, there are probably several reasons why worldwide we have seen that with heart transplant, for example, right? Why is then going to number one? This is not a life-saving procedure. The quality of life, no, for livers is different. You have no alternative, patient die, etc. So with better outcome, you have more cases, more indications, etc. Here, obviously, is not the case. I think another factor, and that's more questions that are common, is probably reimbursement, right? There's I don't know how it is. You don't operate patients just for money, certainly not. But now we are guided by the administration, by budget and many things, which is a shift in many places in the world. And here, I don't know how is the reimbursement for the pancreas transplant or KP, kidney pancreas transplant for mothers. But maybe the main reason is come from the nephrologist and from the endocrinologist that they have the pump of the industry. And they always come and say, why do you have to transplant an entire organ just to get a few cells and produce some insulin? And this is clear. There are progress, there are some pump, and people predict that maybe we will not have a need for that. But I think you demonstrate it's clear that today is still probably the better option if you have the indication that you show, renal failure and problem with diabetes. So certainly the best, and there is even groups that do it preemptively, the sooner the better. I think you've also shown that. Just one question, the islet. I think this is not the topic today. We also see that the islet transplant is going down in many places. Could you just shortly how the islet transplant compare with the pancreas transplant, because that's clearly a less risky operation in this? And my second question that I would just, what is the cutoff for age for the donor, for the organ, that you say that they are older, etc.? What are the criteria? Do we use DCD organ for pancreas or not? And do you have an age limit or BMI limit that we will just turn down and not use the organ?
So coming to your first question, regarding the islet cell transplantation, this is more for patients. So with islet cell transplantation, the rate of insulin independence for a long time is about 50%, and you usually need more procedures. So islet cell transplantation is something to consider for patients that have acute diabetic complications like hypoglycemia unawareness. And so there might be achieved a better control of this. But this is not really for the long term. Coming to your second question, the age limit for donors is around 50 years. We also have some donors older than 50, but this is considered a bit of the cutoff. And DCD pancreas transplantation, we did not talk about this, but it is a topic and it is performed in the UK, for example, and the results are about similar to DBD transplantation. We performed 2 DCD transplantations here in Switzerland so far in the last year, and we had excellent results with them as well. But it is to consider that especially the procurement is more difficult and longer surgical training, of course. Yeah. But the results are comparable to DBD pancreas transplantation.
Thank you very much. Very nice talk. I have a question similar to there are these new insulin pumps. They're improving as well. Obviously, they won't be insulin free, but is there any data on the quality of life comparing people with modern insulin pumps compared to the transplantation, and also maybe endpoints like morbidity for the diabetes?
Yeah, the one thing to consider is you have the surgical morbidity when you go for the pancreas transplantation, and then you have the immunosuppression lifelong. When you have insulin pumps, of course the morbidity is lower and the glycemic control can be comparable to the pancreas transplantation. However, there are still problems with the hypoglycemia, and this is why the pump does not fit for all patients. Yeah.
First of all, Franz, Fabian, thank you very much. It was a very good presentation. What we do have to realize is that the patients are getting older when they come to the complication after type 1 diabetes. And there is new literature showing that living donor kidney transplantation could be just as good. So probably the gap will going apart after about 15 years, what new data shows. So that's why if a 60 or 65-year-old patient comes with diabetic nephropathy, live donor kidney transplantation might be better. And this is why the numbers are tending to come down. But on the other hand, yes, I still think it's the gold standard. And results are excellent. DCD, it's probably like kidney. There's no difference. We did the first 2 DCDs in Switzerland. We're the only one who did this. I think it's a very good option.
Okay, good. Thank you. Thank you very much.